Okay. Hi, everybody. Good afternoon. I want to thank you for joining our compliance webinar today. Since we are a smaller group today, I thought we would do some intros. Hi, Ruth. I don't know if you can, I'm going to try to unmute you. But I have some current clients on the call, and I know a few of you are still hopping on, so I'll just get right into it. Most of you know me. For those of you that don't, my name is Hani Gluck. I am the owner and CEO of 40 Global. We help medical billing companies grow and scale their business by using our offshore team in India. We do charge posting, payment posting, AR, coding, reporting, analytics, and we work exclusively with billing companies. I met a number of my clients in March and was fortunate to build some strong relationships and learn some things from my clients, which I hope to be able to share with you in the coming months. I ended my travel with a trip to San Francisco at the MBEC conference where I met Bonnie Flom. Bonnie owns a medical billing company in Minneapolis. She worked in a rural hospital for 10 years from 84 to 94, and she started a billing company in 94. She had it for 12 years, sold it in 06. She wrote a book for Pearson Education that they use in colleges to train medical billing students. In 2009, she started another billing company called Billing Buddies, and she works with allied professionals like chiropractors, speech, and occupational therapists. Bonnie has served on the Provider Education Training Committee for 6 years and joined the Minnesota Uniformative Committee. She is passionate about law and teaching companies how to apply compliance to their own businesses. So without further ado, I'm going to let Bonnie get right into it. Hi, Bonnie.
Hi, Chani. Thank you for the introduction. And I am going to just show the screen here of we're going through the OIG compliance program. And just a little side note, if you do go to oig.gov, you can look up the same compliance program that they recommend, and they have different programs for different sizes of businesses. And what I'm going to be covering today is for the individual and small group practices. My contact information is on there in case you wanted to contact me. So just to get started, one thing that was really important to me is when HIPAA came out in 1996, and it first affected all of the banking industry and insurance industry, and not the providers until early 2000. I was really instrumental in helping my providers get a HIPAA manual. Well, then this OIG manual came out, and I think there's a lot of confusion about what the difference is between an OIG compliance program or compliance manual in the HIPAA manuals. And to start with a little background, the OIG compliance program was originally recommended in June of 2000, June 12th, 2000, and I have the Federal Register if you're one of those people who like to look things up. And really their goal was to engage the private healthcare community and help prevent them from submitting erroneous claims and combating fraudulent conduct. The recommended outline for back in 2000 till the current has never changed. It's been the same 7 components. There's 7 recommended chapters. And back in 2010, when the Affordable Care Act was passed, which was the largest domestic piece of legislation to ever pass in our industry, it required any provider that sees a Medicare or Medicaid patient or its Advantage plans, so Medicare Advantage or the managed care Medicaid plans, they must have a compliance program, and that's in section 6401. Do you have anything you want to add with that, Chani?
So, no, just keep going. Let's just go through the material and then we'll kind of do a little bit of back.
Okay. Yeah, sounds good. So the OIG compliance program, the biggest difference is the OIG really relates that to fraud and abuse. And there's critical components of the law, like the anti-kickback statute, fee splitting statutes that are under CMS, Centers for Medicare and Medicaid Services. And the OIG wants providers to have their own compliance plan to make sure they don't they're aware of the fraud and abuse guidelines and try, make every effort not to go against them. And in the compliance program, we review documentation, coding, and billing, medical necessity and erroneous payments. And it really focuses, again, if you do any kind of billing for a federal program where dollars are coming from Centers for Medicare and Medicaid Services, the providers really need to have a compliance program. Whereas the HIPAA manuals, which came in, the privacy was required in 2003, and then the security was 2005, and then they've changed a couple times and had updated editions. The latest one was in 2013. That really centers around data and the patient's privacy and securing the protected health information that all of us exchange through the practice of business. And so one is really working with fraud and abuse, coding and billing. The other one is really working around securing data and privacy. Commonly, clinics are where they need to inform patients of privacy notices, which I find is interesting. If you really dig into those privacy notices, what we're really telling the patient is if it's in regards to treatment, payment, or operations, which is TPO, their data isn't private and it can be exchanged without their permission, which is the critical part of HIPAA, why each patient needs to sign off on that privacy notice to know that their data isn't really private if it's related to those three circumstances. Also, HIPAA works with securing patient data through passwords and protecting it. And it also covers appropriate methods to exchange data between covered entities. In 2013, billing services became covered entities with the Omnibus Budget Act. And so this really pertains to providers, which are covered entities, but it also pertains to us billing centers. We need to also have a compliance program and a HIPAA privacy and a HIPAA security manual.
Okay, so today we're going to be covering, just to clarify, we're going to be covering how to do a compliance plan for your clients, but we're also going to talk about how to do your own compliance plan, right?
Correct.
Like the outline of it. Okay, just so everybody's clear about, what we're talking about here.
And I have a sample clinic that everyone could use kind of as a springboard to start creating their own compliance program if they haven't. It's real important, those 7 chapters that I talked about on the last slide, that we'll be covering again and again. Those are the essence of this manual.
Okay, so if you take a look at your handouts on the side, there are 2 handouts. You'll be able to see that there's one called Sample Clinic, Bonnie. That's the one, right?
That's right. That's coming up. Exactly.
Okay, so if you guys open that, later we can, get more into that. But okay, Bonnie, just continue with it. And if anybody has any questions, you can type it in the question box so we can address it.
Okay, so next what we're going to do is review a sample clinic, what a manual would look like either for a practice or a billing service could use the same format, would use the same format, and then we'll also have some question time. What I like to do for my practices, because so much of compliancy centers around making billing efficient, I like to work with my practices to have their own compliance manual. And I have found that many clinics, I would say 75% of the clinics, aren't even aware. It's not even on the radar that they need a compliance manual. So this is a really good service to offer our clinics, and it really helps us as well, because we need to be able to get accurate data and compliant data to do our job. So I make I have a template, and I put their logo on the front here and their name, and on the next page there's a statement of compliance. This just briefly tells the OIG that the clinic or the billing service has and will be continued to be committed to the highest standards of integrity and accountability. One thing that the OIG has stated is that clinics that are compliant and continually work a compliance manual, if they are audited, it shows that they have shown good faith and made every effort to be compliant and do the right thing as far as billing and coding and charting. And this manual, this template, isn't something you get and do and you're done with. It's something that's an ongoing work. They want everyone to educate their employees, and there's logs of education. They want within 90 days of a new employee to be trained, and annually have everyone trained, as well as doing quarterly mini audits and documenting that in logs as well. One of the items that I see as a billing company, and I'm sure many people on the call can relate to, is some of the contract payers like Blue Cross and Humana, Medica. Will send out, if you do the managed care programs for Medicare or Medicaid, that annually you need to review the fraud and abuse guidelines for Medicare and attest to it. And that's exactly what this book is about, is making sure that we comply with the fraud and abuse guidelines with CMS. It also, the OIG recommends for efficiency that the clinics tie into this, their policies and procedures, and use this as a template to train their staff. As I go forward with the book, I'll show some more areas where you can add some ideas on adding policies and procedures to this manual on top of the critical fraud and abuse areas. So again, there's 7 chapters. That's the core. That's always been out there that the OIG wants us to have. The first one, we designate a compliance officer, and it's interesting to note that the compliance officer is in charge of the OIG compliance plan, but also in charge of the HIPAA privacy and the HIPAA security officers. They're the lead officer. And chapter 2 is the chapter where we're going to be continually updating and integrating our manual as we go through and find different things that we need to do in our businesses to be compliant. We're going to add to chapter 2. And chapter 3 through 7 are really areas where we're going to do training, educating, monitoring, and logging our activities within the business. So the chapter 1 is real straightforward. It talks about who the compliance officer is. The compliance officer is going to be in charge of developing, educating, monitoring, and assisting all activities that occur within the practice or business, as well as assert disciplinary action as needed. The OIG felt that discipline was so important to enforce a compliance plan. They made a chapter just on disciplinary actions and a log on disciplinary actions. This also goes through again that the compliance officer is in charge of the HIPAA privacy and the HIPAA security officer. In a lot of small businesses, it can be the same person, but it's an important part to note in larger practices that the OIG compliance officer is the lead officer. So chapter 2, which is the meat of everything, I ended up, as I find important items to add to the manual, I make up addendums, and we can see right away Addendum A is the CMS Fraud and Abuse Guidelines, and that's a 20-page addendum. And I'm just going to cruise down there for a second. When I'm training clients on the compliance plan, this Fraud and Abuse Guidelines is a really good article that Centers for Medicare and Medicaid has put out on all of the critical laws that they need to comply with. The False Claim Act, the Anti-Kickback Statute, the Physician Self-Referral. The exclusions is the newest one added here, where there's actually a site at the OIG that we're responsible as billing agencies and as practices to make sure that we aren't dealing with anyone that has been excluded from the federal programs. And you can actually look up people's names, and you not only can, you should make sure that there's no one you're dealing with that's been excluded from a program. It's published on the OIG's website. So I don't go through this 20-page guidelines page by page with my clients, but I pointed out to them the Addendum A and talk about how important it is that they review that. And then I go through some sample stories of what each one of these critical pieces of legislation has led us to do, so we're sure that we comply with fraud and abuse guidelines. One thing, many of us know that the claim form is really a piece of attestation that represents our medical records. So the claim form needs to match our medical record. The False Claims Act is really what's driving that. I always like to compare it to tax season, which is timely. Yesterday was tax day. And with tax season, when we send in our return, we're attesting that we have everything to back up that return. We don't send in all the receipts and all the supporting documentation. And that's very similar to what we're doing with billing. When we're sending in a claim form, we're attesting that we have the records to support that this is a representation of what occurred in the office, and our medical records will validate that. So the False Claims Act is one area where the practice is validating documentation of billing of claims to ensure that they all meet with medical necessity guidelines, are billed according to the rules and regulations set forth by CMS. Other areas that come into the False Claims Act is the appropriate use of modifiers, making sure that you're not unbundling anything, which they consider double billing if you're unbundling inappropriately. So there's a lot of things considered in the False Claims Act, and that 20-page handout really covers a lot of those circumstances. Next, the Anti-Kickback Statute. It's not uncommon for me to find clinics that are violating this. This is saying the practice will assure that no remuneration is received either directly or indirectly to induce or reward referrals of items or services reimbursed by the federal healthcare program. And in business, it's not uncommon to reward someone with a referral. If you car dealerships will, if you bring a family member in, they'll give you a discount on a car, or different practices, groceries I see all the time, or Amazon. If you refer 10 people, you'll get $10 per person. You can't do that in healthcare. And where I see problems in healthcare, I had a practice that was giving away free T-shirts for anyone that referred a family or friend to the practice. And again, you can't induce or reward referrals with items or services. Or another practice was giving away a free massage if you referred someone. I had someone giving free Starbucks cards for referrals. And you really can't do that in healthcare. That they look at it as an inducement. They want it to be true, that the reason people are seeking healthcare is because not that they were referred by someone, but that was a medical necessity issue that needed to be addressed. The next item, the physician self-referral law. That's where a practice will neither accept referrals or make referrals to an entity in which the practice has ownership or interest in. I had a provider who wasn't in the Blue Cross network, and he purchased another clinic that was in the Blue Cross network. And if he got a Blue Cross patient at one clinic that was not in the network, he'd refer it to the clinic that was in the network. In that, he ended up losing his license for. It was a pretty serious offense. The Social Security Act, that goes through all the Medicare rules and regulations that we comply with. In this exclusion statute, again, that's where we agree not to collaborate with any person who's been excluded from the Medicare program. And that's right on the OIG.gov's website. If you look up exclusion statute, you can find the list and see all the people. There's many people out there that have been excluded. You can just put a letter in there like A, B, or C, and it'll pop up hundreds, literally, of people that have been excluded from the Medicare program. Do you have any input, Chani, or would you like me to continue? Or
No, just keep going. I think this is good. Again, if anyone has any questions, just put it in the chat and we can put it in there. But basically, Bonnie, this is a format of what you use when you create a manual. You follow chapter 2 and you go through these 5 questions or 5 items with the practice.
Right. And then after this, I incorporate provider billing practices, documentation, charting, and coding. And these areas really help expedite and support what we do as a billing entity. Some of the things that we focus on is making sure they understand, the unbundling issues, where a lot of providers want to put the 25 on everything because they know it'll be paid, where we work with them to make sure that they understand that their coding needs to show that that's a separate and distinct procedure, that service, that it can't be just put a 25 on an E&M code to get it paid. So we use this to support a lot of what we do. Another issue is refund balances. That's part of the False Claims Act, that the provider needs to refund within 60 days. And so we can use this manual to help educate the providers and make it work well with our company too. Then the OIG recommended that the clinics and the businesses offer another section that goes through the policies and procedures for the different office positions. When you read the directive from the OIG, they look at that as this is really going to streamline the practice or the business and save time and money. And I did have one practice in particular that I can think of that gave everyone a clipboard, from the front desk to the biller, the person who did marketing, the inventory purchasing, the office coordinator. And in this one practice, the biller or the front desk person actually took a clipboard and started the day from opening the door, unlocking, the door, turning on the lights, opening the safe, cashing in the drawer, getting the new patients ready. She documented each and every step of her position. And it turned out about 3 months after she had done that, she ended up accepting a position at another place. And the clinic was really thankful that, this process had been done. It really helped them as a business.
That's great. That's great that you have this all outlined. So for all the people that are on the call right now, you have this sample that you can download from the handout section on the GoToWebinar control panel. And you can really use this for for all of your clients. It's all Bonnie has been so kind to put this all together for us to make it easy to just go in and present this to your clients. But I think it's also a great tool to have those conversations at the beginning of the relationship of a new client, because Bonnie, you really touch on all the trigger points of issues and problems that happen, maybe 6 months or a year into a relationship when you're like, hey, we have all these credit balances. How do you want to handle it? Right? Or we
Right.
have this where you told us to put the 25 modifier and everything, but that's really not okay. So you're kind of like preempting any issues in the beginning of stages of the relationship to kind of make it for a smoother working relationship. Right? Is
Right.
that
That's exactly right. It really helps you. And it can be a really good selling tool too, because many providers don't realize they need a compliance manual. So you're educating them, and also you're assisting them in getting compliant, which they need to be one way or the other. So it is really a good closing tool too, to getting new business. Um, Another thing I wanted to add quick is this is just a template. And as I've gone through this, I'll add things to here, like the red flags rule, for example, tells the practice to take a copy of the patient's ID card and their insurance card to ensure identity. So it'll prevent more identity theft. So I've added that as I've gone along. I've incorporated a hardship policy that each practice maintains yearly. The hardship policies, if you've worked with them in the past, want you to use the federal poverty guidelines, and that is published and changed the first of each year. So this is really just a real stripped down version of things you must have, and some ideas of what you can have, but there definitely is so much more to add to this. And other areas I've added is each provider has its own contracts, and some of the contracts require they have a special waiver signed if, for example, Landmark or Cairo Care require a special waiver signed for their patients if you have a contract with them. So you can go through who are the contract payers for your providers and what do they require be done in regards to coding, charting, and billing, and incorporate that. So this is really a stripped down version, but it incorporates all the chapters you have to have, and is a real good springboard to create your own manual.
Okay, so talk to us more about how you're using this as a selling tool and how much do you charge? Give us an idea of what you charge for doing this.
Sure. So
Yeah.
what I've done, there's a lot of times as a billing agency, and I'm sure many people out there that do billing will get calls from people that say, I really, don't need a billing company, but I really would like someone to help, make sure we're doing everything right, and we have all our ducks in a row. What I do with those people is I steer them towards this compliance manual, and I charge $3.29 for it. And when I first made it up, it probably took me 8 to 10 hours to research everything and get a good template going. Now I can probably make a manual in about 20 minutes with their logo and compliance officer's name and clinic name. And then I spend an hour and a half going through the different areas with them. And I make sure that they understand that this is not a finished product. It's never a finished product. They need to always be adding to it. And as we go through the next 4 chapters, we'll see that there's logs that go with this for them to do mini audits. But it's a nice side revenue, and it's also something that most practices that I've encountered need. They're not aware of the rules and regulations, and that's why I also put in here this presentation where the rules can be found.
Okay, wonderful. So out of all the clients that you've asked or offered this to, what percentage of people have wanted to go ahead and do it?
Everyone I talk to wants to do it, and I have to say I probably get 60 to 70% who will actually schedule a time with me to do it. So it's something that will come up over and over in conversations, especially if we're having issues with credit refunds or, modifiers or unbundling or anything like that. I'll say, we really need to get into that compliance manual. When would you have an hour that we could go through that? Or I might know they have a new employee, and I'll remind them that the OIG really requires they have a compliance manual, and train the new employees and in their existing employees. But that's a good question, Chani, and I would say that probably 60 to 70% take me up on it, and the other 30 to 40% still need to be done. I'm still at work with them to get them in compliant.
Okay, so do you have a process, or you just have a list of questions, or you just work through this document?
I work through this document, and as we're working through it, a lot of times things will come up. One of the rules where you have uniform charging, where practices are supposed to charge everyone uniformly, and you can deviate that on two circumstances. There's a time of service, or they call it a paperless discount if they pay a time of service, or a hardship discount. I'll get a feel for what they're doing with that, if they are following the rules, and we incorporate that. I make sure the red flags rule, that they're getting copies of the ID and insurance cards. So as we go through it and we're talking through it, we do change quite a few things. And again, a lot of them will take me up on the offer and document their other positions. So this is just a good start, a good template.
Okay. I'm curious if anyone on the call has something like this in place and how it's working for them. So if you have something like this and you want to share I'm going to unmute everybody. And, we're open to hearing what you guys are doing, and if there's anything, anyone on the call wants to share just to add value to what we're talking about. But Bonnie, why don't you continue with the material that you have, because we have a little bit more time to go, and then
Okay.
we could save some time at the end for some questions and talking about our future masterminds.
So chapter 3 is a chapter that covers the training and education of all the staff members, and again, the compliance officer is in charge of doing that. And there's a log to go with this, and it's at the end of the presentation. I'll get to the logs in a minute. And when I'm going through training the practices, I have them start the log today. Today is the day that they got their first education, and they fill out, date it, put in who attended the training, and a detail about that. And so they start the program the day I teach them. And then I try to teach the compliance officer and really encourage the compliance officer to turn and teach their staff members, so they take ownership of it and feel comfortable doing that. I don't know if you've heard the saying, watch one, do one, train one. I once had a doctor tell me in medical school that was their mantra, is they would watch a procedure done, they would do a procedure, and then they would train a procedure. And by doing that course, you can lock in and save the information better to memory. So I try to train the compliance officer and get that compliance officer to commit as soon as possible to train the rest of their staff. And that's all documented in the log for chapter 3. in chapter 4, this is part that's really we put the work to the manual. What you're doing is conducting and documenting mini audits throughout the years. They call them regular audits. You could interpret that to be monthly, or they don't give you an actual timeline. I encourage quarterly to do a mini audit. For example, the clinics that I work with oftentimes have time of service discounts. Well, time of service discounts need to be offered uniformly. Like, say an auto carrier wanted to get a time of service discount, they could get that if they paid at the time of service. They could prepay a package for a patient. And nobody gets that time of service discount unless they actually pay. So if their credit card gets declined or they forget their checkbook, we're not carrying a balance at a lower rate for a patient than we're carrying a balance for the insurance companies. So that would be an area we could do an audit, or we could do a mini audit to make sure we have all the signatures to do billing, the signatures on file that are required on, if you look on a simple claim form, box 12 and 13, we typically, as billers, are saying we have signatures on file. That would be a good area to audit. Is there really signatures on file? Or is the 25 modifier substantiated? And there's a log for this for chapter 4, and I'll show you that. Chapter 5 isn't a log. I kind of find this, it's really important, but it's also, in my mind, a little bit humorous. The OIG felt that it was so important for compliancy that the office felt open and were able to discuss any forms of compliancy and have a frank discussion, had open lines of communication, that they wrote a chapter just on that. And they have recommendations in there that if they felt there was a need to even have an anonymous tip box where they could put, we don't think this is being followed, and there wouldn't be any retribution by other staff members. So chapter 5 doesn't have a log, but it's an important piece. Chapter 6 has its own log, and if we find anything where the clinic's doing something wrong, we write down the detected offenses and develop a corrective action plan. I thought this was particularly important because we do find things in our course of business where things aren't being done right. And they looked at it, the OIG, that we should find things. I mean, none of us are perfect. We're going to find things. But by listing them in this manual and showing that we made a good faith effort to identify them, correct them, and move forward, should that come up in the future that, we've maybe weren't aware we should be doing refunds in 60 days, and we identified that and made a plan for that, if that ever is discovered in an audit or something going forward, we can point to the fact that we've identified that and corrected our ways and have a developed corrective action plan to move forward. So that has a log. And the last chapter is kind of the ugly chapter, I always think of it, but necessary. The OIG wants us to enforce disciplinary standards so that everyone in the office takes compliancy serious, in that if they want a procession of how we're going to enforce a policy that's not being followed. And so maybe the first offense, we give an oral warning, and if they don't correct the action, we give a written warning. And then if it doesn't correct, if the person doesn't correct their behavior, then they would be terminated. And they want that course of disciplinary actions outlined in chapter 7, and there's a log to go with that. One log I didn't discuss, but with each of our specialties, we have certain charting, coding, and document guidelines. And what I do by specialty is I put, like there's an addendum here, this toolbar, I'll scoot it out. This is a chiropractic sample, so I put an addendum B in there, which is Medicare's Benefit Policy Manual, section 240. This is the actual section that Medicare uses to audit chiropractors. And so if this was a chiropractic specialty, I would have addendum B be that rule, and we would cover that rule.
Okay,
So
we have
go
some
ahead.
questions coming in. So let me just, okay, so Joan wants to know, once it's your contact information. Joan, I just emailed it to you, so you have Bonnie's contact information. And Susan, you want to know if, how do you handle a practice that, and this is for Bonnie, how do you handle a practice that refuses to refund? How would you handle that situation?
What I do is we keep logs of each month requesting the refunds be done. And you know that it is a tough question because it can become a deal breaker if they're not compliant with that. And it's a personal preference. I mean, really, they need to do the refunds. We cover ourselves by making sure we've documented the request that they refund. But ultimately, we don't have the ability to refund them. So we keep logs of our requests.
Okay.
Good
Susan,
question.
does that answer? Susan, does that answer your question? I sent you an audio pin so you can talk if you use that audio pin, but if not, you could just reply in the chat as well. Okay.
All right. So at the end of the first 11 pages, I've got the template down to that. Then I have my addendum with my fraud and abuse guidelines. That was addendum A. And again, that was like 20 pages long. And I don't read this to my clients or go through everything with them, but I encourage them and pointed out that there's good material in there for them to know that they're compliant with the CMS fraud and abuse guidelines. Then I incorporate some charting and coding rules for the specialty type that I'm dealing with, and that's addendum B. And then at the end of that is my logs. That in chapter 3 referenced addendum C. This is the education log where we would put the date of training, like today's date, the employee's name I trained, the original compliance manual training, and a little bit of detail. And then again, I encourage that compliance officer to turn around and train their other staff members, and that log is kept here. And any new members need to be trained, and also they want us to retrain yearly, which is why we're getting all of those attestation training memorandums from insurance companies, is because the CMS fraud and abuse wants each company to go through the training yearly. So there's a log for that. D, this is where we're going to pick an area in chapter 2. Chapter 2 is the meat of our compliancy, what we're going to follow as our rules. And we're going to pick one area each quarter and monitor it. For example, I said signatures or 25 modifiers, or different specialties have different modifiers, meaning that the doctor charted and coded something. That would be a real good area to monitor. Hardship is another area. You can't just write off money because somebody says they're having a hard time. You need to document hardship based on income. So, maybe we could see how many write-offs we had through the quarter and what we found. Then chapter 6 is if we found something in chapter 4 that was wrong, maybe we're missing signatures on file, we write down what our finding is and what we took as a corrective action to remedy the situation. And then Chapter 7 has its own log on how we're going to enforce our actions from Chapter 6. If we find a corrective action, what did we do as far as enforcement to make sure that doesn't happen again, whatever we found we needed to correct.
Bonnie, could you speak a little bit about your, because Susan and I are corresponding. I guess I couldn't unmute Susan, so we didn't hear her response. But what do you think, in your opinion, and I know you're not an attorney, but is there what kind of liability is it to billing service that does not do the refunds? Like the physician or practice doesn't want to do refunds? How do you know how a billing company is liable for that?
You know, I am a member of AMBA, and they have their own legal counsel that goes through this at webinars, and um, they're they take the tougher road to say that, you know, we are responsible for making sure our providers refund. And, you know, frankly, from my perspective, is I don't have the checkbook. I can't do the refunds, but I do everything within my means to make sure that they're aware there's a refund needed, and I feel that alleviates my responsibility. I've done everything I can, short of writing the check
So
for
you're
the
sending
refund.
them a list of all the patients that need refunds, and then you kind of like say, look, I sent you the information. I'm not responsible to actually write the check, but here, these are the patients that need the refund.
Right, right. And we add a note to the patient's account. Every software program has a note-taking area that we requested it. So it really shows that we've made a good faith effort to do our part. But that is a tough area. I agree with the caller that that is a tough area to get compliancy in.
Would you then, if after you let your customer know, okay, these are the patients that need refunds, will you then take the credit balance off the account, or it still stays there? Or what do you
Um,
advise?
what I have done is we'll post a refund request, it's called, into the account. And then once they refund the money, we change the refund request to a refund done. So we have a transaction. Every software, you can make up your own code set or your own transaction code. So we have a trail so we know the refund request was sent, and we take it off the books. When the doctor lets us know, you know, the patient was refunded $56 with check 101, then we take the refund request and move it to refund done and put that note in, provider sent check with that refund note, check number 101 for $56 on April 18th. And so we track it that way. But we don't leave the refunds on the books, because then we're paying staff over and over to work the same refund. And we do wait till it's close to the 60-day mark to request them to refund, because we want to make sure that the patient isn't going to have a newer balance to apply it to. So we're the type of billing we have a lot of reoccurring visits where with allied specialties like chiropractic and occupational therapy, speech therapy. Patients come in over and over repeatedly, so they could have a credit, but then next week it will come back that we can apply it to a future visit.
Okay. I just changed something here. Okay, Ruth, I know you're raising your hand. If you can just put the access code of #63#, and then you can unmute yourself. I don't know if you're able to do that, but that's what you have to do to just, here we go. Okay, Ruth, okay, we could hear
Yes,
you
can
now,
you hear
Ruth.
me? Okay.
Yeah,
Okay, I
go ahead.
apologize. I was starting to type, but it's kind of long, so I appreciate you letting me ask you. It's really funny you would speak of this because literally right before this meeting started, I was on the phone with a client, and we mostly work with physical therapists, so Bonnie, the same way. Sometimes they hold patient refunds for several months because the patients do typically come back very often, and they use those credits. They actually have a form that says, do you want this back or do you want to hold it for another course of treatment, and that they have patients sign, and a lot of them want to hold it. But at any rate, they called to say, does this patient still have a credit? And I said, no. We sent in a refund request in June of 2016, and 2 weeks later, you sent me back a check number. So I entered that into the account and took that credit off of the account, referencing the check number that you said you mailed to the patient. And then she finally said, oh, well, there's a stack of checks in here that have never been mailed.
Oh, no.
So what kind of, it's so funny you said that because my heart was just pounding thinking, okay, so what kind, do I have any liability for that at all?
I wouldn't know, like Chani said, you'd have to talk with a lawyer, but it sure
Attorney.
seems an attorney that you made a good faith effort to do everything right. And, you have no negligence that I can see on your part. You requested it. You were told they refunded it. You can't be there to send out the check, so I think you did everything right.
But now that I know, do I have any other further responsibilities?
Well, you can't really, yeah, you really can't. You don't even know which patients that they were sent or not sent or.
True. Okay. Thank you.
Okay.
Thank you.
So Bonnie's information is on the screen for those of you who want to reach out or have any questions or compliance issues. I know Bonnie's been extremely generous with her time and her knowledge, and you've put a lot into this and spent a lot of time researching this. And I think that you have, great wealth of knowledge, in this area that that a lot of us can benefit from. And you could also use this compliance plan for your own businesses. So if you, as a billing company, don't have a compliance plan, this may just be a very quick, easy way to start and have something to work with. And again, if you have any questions about that, please feel free to reach out to Bonnie. Just wanted to talk about our next mastermind. We have something scheduled on the books for May 9th. To be honest, I don't have a topic. I know it's going to be something on operations, but I don't have it all formulated at this very moment. So I'm definitely open to feedback and suggestions from any of you on the call, or if you guys want to email me and let me know what's of interest to you, or even in the chat, you can tell me what you want to talk about. I'd be happy to do that. I'm always looking for people that have some wisdom. All of you are so brilliant in your own ways, have really navigated your businesses and learned different things. And I'm always trying to figure out, okay, what can any one of us teach the rest of the group and help them grow and build their companies. So happy to get your feedback. Again, I'm really excited. Please mark your calendars for June 6th. We have an EOS implementer. For those of you who are not familiar with EOS, it's the Entrepreneurial Operating System. It's based on the book Traction by Gino Wickman. We're all trying to read that book together because it's basically helping us really scale our businesses. So we decided to just add that additional, book reading club and kind of get some support in reading a business book together. And in preparation for our EOS implementer, who's going to come and do a 90-minute presentation on that. So when I asked her to give me a little blurb of what she was saying, what she's going to talk about, I'll email that to you with the invitation, so you guys can all mark that on your calendars. Um, I think that's it, unless anybody has any other questions, or there's a feedback form at the end of this. So when you close the GoToWebinar control panel, you'll see a little feedback questionnaire come up. Give me your feedback on this webinar, and it has just a couple of questions. You can just let us know how we're doing, the format of how this is run. Some masterminds have been in a webinar format. Other masterminds have been very interactive, where we're all talking with one another. So I'm curious to hear from you guys what your preference is, if you want in a complete webinar style, if you want it more interactive, or if you'd like a combination of both. And that's one of the questions on the feedback form. So we have 4 more minutes to go. So we did finish early. Bonnie, any last words of what you'd like to end the call with?
I just feel that this is something that really can help businesses, billing service businesses, get what they want from the providers, where they can really use that Chapter 2 to call out the important pieces of what we need. It's so important that what we're submitting to the insurance companies, matching the charting and coding of the doctors, and this can be our reason to get everything done right. That's really what I like to focus on with this, is really, this is our reason to get everything done right.
Perfect. Wonderful. Well, thank you so much, Bonnie. Really appreciate your time and your effort in putting this together. Bonnie sent me a bunch of documents with the backups of all the data that she's put together. So if any of you want any more information, I do have more information, or you can reach out to Bonnie directly. Okay. Thank you, ladies, and talk to you next month.
Thank you.
And okay, all the best, everyone. Have a great day.